Okay, recording has started.
Okay, well, thank you, everybody. Thank you, everybody, for attending. We want to welcome everyone to the first ever United Bridges BERG event, Let's Talk About Racism, which is a 4-part quarterly series that was actually started and conceived of by the Asian BERG. Susan Lee and Jeremiah Malari have put a lot of effort into this, and I think you're really going to enjoy it. So we hope that through the panel discussion series, the interethnic and interracial dialogues can create allyship and safe learning spaces to engage and empower team members to individually and collectively advance towards health equity, diversity, and inclusion. We want to start off by saying thank you to the attendees. We appreciate you taking the time out of your day. We know that you are all busy. We want to thank our panelists, who we think are just stellar, and we think you're really going to enjoy this robust discussion. Each of us may be at a different phase of learning how to identify and build an inclusive environment within our workspaces and our communities. We do understand that. We also understand that this is a sensitive and very deep-rooted topic, which will take time and effort to address. So for whatever stage you may be in, we welcome you. We hope that these discussions will help you individually and as a community to change our future. Together, let's choose to create a better tomorrow. At this time, we have three requests for the attendees. Please make sure that you are muted and your cameras are off. We'd also like you to mark your calendars to join us for the next quarterly panel event on June 17th at 5 o'clock, which will be hosted by our Jewish Bridges BERG. And to help the Bridges BERG better understand and really try to see if these talks are making any sort of impact, we'd like you to please take a moment and fill out the pre-survey before we begin. At this time, I'd like to welcome my co-moderator for the evening, Andrea Loney, who is the project manager of equity, diversity, and inclusion at Northwell Health. And I'd like to introduce myself. I'm Janna. I am a radiation oncologist and the director of radiation medicine at Phelps Hospital. We'd like to introduce our panelists. Dr. Alyson Myers, medical director of inpatient diabetes at Northwell Health. Maybe just wave, Alyson. Dr. Myers. Dr. Melissa Boneta Davis, Scientific Director, Global Breast Cancer Subtypes, Weill Cornell Medical. Thank you. Dr. Robert Roswell, Co-Director, Cardiac ICU, Lenox Hill Hospital, Northwell Health. And Dr. Tochi Iroku-Malize, Senior Vice President, Family Medicine, Northwell Health. Thank you all. We are looking forward to a very honest and robust discussion, and we just can't thank you enough for joining us tonight. Before we get started with this evening's conversation, we wanted to show you a quick video just to set the context for our event.
If those were black and brown people there yesterday, there would be bodies on the Capitol today. Bodies. There would be mass arrests. I think it reveals very clearly how some people believe that this country belongs to them, and they act that way, and they're treated as such. An insurrection. I saw a majority white mob with impunity sack the Capitol. I saw them walking, mulling about, threatening people in the Capitol. And I saw police being gentle, relatively gentle, I suppose, giving them space. It was a nation on edge in some ways. White mob violence is a critical feature of American history. At every moment in our history where there has been a sense in which our American form of life, white America's hold on the country seems to be in jeopardy, there's always been this response that borders on violence or is violent. Well, I mean, let's just compare the preparation of the police to respond to Black Lives Matter protests in the summer and how they prepared and responded to this Trump rally. What we saw was an overwhelming show of force. With Lafayette Park, we saw the deployment of resources to clear the park, tear gas, a range of things so that Trump could get his photo op with his Bible.
Is that your Bible?
It's a Bible. What we saw yesterday was no basic show of force. The fact that they could make their way up the steps of the Capitol, onto the bleachers, the stage of the inauguration. They were moving about. The fact that they were able to try to replace the American flag with the Trump flag. We saw photos of Capitol Police or police officers allowing them to pass through barriers. We saw police officers taking selfies. We saw police officers helping people walk down steps. We saw that for some people, citizenship means, right, the exercise of dissent. One could protest without fear of cops or police. One could give voice to this belief that you actually possess the country, that the country is yours.
That's right, we own it, we own you!
There are folks who believe, right, that they have the right to protest because the country is theirs, and they believe that all the other folks should just simply be grateful and shut up.
Let me be very clear. The scenes of chaos at the Capitol do not reflect a true America.
He's lying. You know, I understand the aspirational claim, but he's not telling the truth. At the heart of this country is a contradiction. It's a contradiction born in this idea that we are an example of democracy achieved, and yet we held chattel slaves. We've been dealing with the failure of holding these folk to account since our founding. We coddle and cuddle white supremacists. We compromise with folk who hold these views. That's the lie that's at the heart of the American project. Right? The contradiction that this place is the reserve for white people only, and everyone else should be thankful. You know, there's this ongoing American ritual where you have this kind of acting out, and then people will immediately start talking about unity and turning the page.
This moment calls for healing and reconciliation.
There's never been anything we can't do when we do it together.
We're at an inflection point. We're in the middle of a reckoning. And I'm not talking about the election of John Ossoff and Raphael Warnock alone. What I'm talking about is what made that possible. Everyday, ordinary people, right, seizing power for themselves and shifting the political landscape of Georgia. What we saw was the beginning of the birth of a new America. We saw the crown of a new America. So we got to be better midwives. But that happened alongside of the death throes of an old America. That was a rally around white grievance, around white resentment, around white hatreds. It was a rally about white fragility in so many ways.
We're gathered together in the heart of our nation's capital for one very, very basic and simple reason: to save our democracy.
What we saw is an older America clinging to life. It's in its death throes. It knows that its days are numbered. At the end of the day, I would say, choose your side. There's no in between. There's no in between. That's what I would say.
The secret to amazing hair? Dove believes you get a...
Wow, what a powerful video and a great foundation for us to jump right into this conversation. I don't know about all of you tuning in, but you know, throughout the weeks of preparing for this evening's event and watching that video over and over and over again, it certainly triggered a number of thoughts, feelings, and emotions. And you know, when we think about unconscious bias and inequity in healthcare delivery, specifically in the Black community, we have to talk about and acknowledge both the systemic and systematic racism in this country that has allowed for institutions to create these biases and to create these inequities as it relates to healthcare. So for everyone who was able to tune in and watch the video, I have the chat open. So if you see my eyes moving, it's because I'm tuned in there. But I would love for all of you to start posting some of your initial reactions to watching that video. I know a few weeks ago, we were all at work or doing whatever we were doing at the time, and watching all of those events unfold, and certainly made it extremely difficult for us to work and manage what we were thinking and what we were feeling in real time. So for our panelists, just to kind of warm up this conversation this evening, I would love to invite maybe one or two of you just to share what were you feeling as we watched that video, and how that connected to what you felt in real time back in January.
I'll take a stab. Just watching that video again just really puts me back to where I was, and just in a state of awe. And it's hard to, it's really hard to stomach. I think, I'm reliving that moment again where we were upset about what was happening at the Capitol, but also doubly upset of, if that were a minority, if that were a Black or brown person, what will be happening to them. And I just thought that was such a perfect and a clear example about the ways people are treated in this country. And it was very, very, again, hurtful. And it was a platform for a lot of conversations with a lot of people, because immediately I saw news anchors discussing this, and I thought, this is a perfect platform for discussion. If people didn't really understand differences in treatment, just really juxtaposing the Black Lives Matter movement and what was happening with the insurrection of the Capitol, and just looking at the response and just having a conversation about that. I had it with my family and other people. It was an awakening to really discuss differential treatment in this country.
Absolutely. Thank you so much, Dr. Roswell. Dr. Iroku, maybe I could turn it over to you. Being one of our leaders here at Northwell, both in a clinical and non-clinical capacity, I can imagine how many of your peers at that level are coming to you and just seeking guidance, direction, insight, advice. Would love to maybe get a thought from you on what you were thinking and feeling in that moment, and the types of conversations you were having with colleagues that day.
So
I think we may be frozen.
it was a triggering event during, especially, can you hear me?
Yes.
Yes? All right, so people were holding their breath. So there were a lot of people that were anxious going on. January was, there are a lot of people that I spoke to that were actually not going to relax until the end of the month. They did not believe that everything was okay until the end of the month. They said, well, let's wait and see. What happens. They're very, very cynical because of, and January 6th was kind of like really, you see, and the distrust and the fear that people had held, their uncertainty. And so really for those who, it was just a matter of just listening, letting everyone vent and speak their truth of how they were feeling, acknowledging that they were feeling that way, and thinking about what do we have to do going forward, because a lot of people are tired. It's been a tough year, right? 2020 was tough for many reasons. And just what do we do going forward? How do we advocate better? How do we move forward and make some changes? As he said, you have to pick sides. And so how do you pick your side and then work towards that? So.
Well said, thank you. So given the topic that we're going to be discussing this evening, unconscious bias, I thought it would be great for us to ground ourselves in a definition that we could all be rooted in for this discussion. And this is a definition that for all of our Northwell team members, if you've participated in our unconscious bias training, this particular definition may look very familiar to you or sound familiar to you. So unconscious bias it is an automatic response from our brain in which we take in information and make a quick judgment about it. It happens without our awareness, intention, or control. So I know this is a very complex term that we've been hearing so much over the past several years, but to keep it simple and concise, we wanted to ground ourselves in that definition. So let's jump right into the first question, and this will actually be for you, Dr. Davis. Racial and ethnic minorities are more likely to experience social, economic, and environmental inequities, and racial and ethnic minorities have less access to healthcare. You are an oncologic anthropologist. Can you tell us what exactly that means and discuss your thoughts on how race as a construct has the potential to be weaponized in medicine?
Great. So first of all, thank you for inviting me. I'm very honored to be a part of the panel. And I'll answer the question and also in the context of my sort of experience and reactions to what happened back in January. So first of all, oncologic anthropology just means that we're studying not only the people who have cancer from the perspective of a cancer diagnosis, but also their social history. And a lot of that has to do with, for instance, not only their racial background, but their genetic ancestry. And this goes all the way back to, for instance, for African Americans, our African origins as well. And so in the context of susceptibilities to cancer and specific types of cancer, we aggregate different types of information to help us understand the biology and the biological determinants that can impact health outcomes. And so then, to address your question about weaponizing race. So first of all, when I hear that word weaponizing as a scientist, I often think of it as, taking a tool or something that is meant to be benign or something that's meant to be helpful and then somehow altering it to harm people. And so when I think about race being weaponized, I think about that in the context of gatekeeping power, right? So in the initial stages of how race was actually formed in this country as a social construct, it was certainly meant to harness power for some and limit power for others. And so that marginalization, has become basically harmful, right? So in order to have access to healthcare, in order to have access to any of the resources really for well-being in general, some of us of a specific race group have very easy access to those things, and others of us can never access it in our lifetime, in generations even. And so I think that a lot of that harmful outcome of race has led to the atrocity, because of the atrocities on these minority groups, has led to mistrust in our communities. And so then I circle back to January 6th. So my reaction at the time was disbelief. I think I was really embedded in my work that day, and my unconscious bias was, where are my children and what should we be doing right now? I don't even know what's happening. I was in a meeting and someone said, "Do you see what's happening at the Capitol?" And I was like, "What Capitol?" And they're attacking the Capitol. I was like, "In which country?" Like, surely you don't mean in Washington or in my state capital. And so like the whole meeting was hijacked. My entire day, in fact, was hijacked. And I remember our churches were issuing, statements for us to stay sheltered because there was a potential race war. And I thought to myself, what has happened? Where are we? What is the era, that I'm living in, that's unfolding around me? And in that moment, I really felt that sort of marginalized pressure around me, right? Because I didn't think I was going to be protected, and I started to feel very vulnerable. And I think that's how a lot of our communities feel every day.
Thank you so much, Dr. Davis. Can you guys hear me a little bit better now? Okay. In that context, I want to turn this next question over to Dr. Iroku-Malize. So we know that social determinants of health have a major impact on patients' health, well-being, quality of life. They are all inclusive, from safe housing, transportation, education, job opportunities, access to nutritious foods, clean water, language and literacy skills. So we know that social determinants of health contribute to healthcare disparities. Dr. Iroku-Malize, can you please touch on some of these, and as a family medicine physician, and tell us how you've seen them play out in your practice with your patients?
So thank you. So as a family medicine physician, so I've had to use my training to be mindful, because we are always taught this is not just the clinical aspects or the medical aspects, scientific aspects, but you have to think about the socioeconomic aspect of a patient's life and how that affects their health and how it affects the health of your patients as well as the community. And we've learned that conditions in which people are grown, where they're born, where they live, where they work, where they die, can't be strictly non-medical factors. So you have to think about all the factors that affect them, especially as my specialty, which is primary care. An example is having a patient, right, who has a chronic illness, such as diabetes or hypertension. So my department in family medicine, we take care of patients, babies to elderly, so it's everywhere. And whether they're in healthcare centers, clinics, shelters, at home, nursing facilities, in the hospital, along the entire continuum of care. So there are patients everywhere at all ages of life. And asking them to change their diet if they have a chronic illness is not as simple if they live in a food desert. That means that the only close source of food may be from a bodega, which may not have fresh food. And what if they do have a supermarket that's close by? The fresh foods are more costly than fast food. So those who live in a shelter may not have access to a stove, so they'll have to use canned goods and a microwave to make their meals. And a person who makes minimum wage will be able to stretch $10 further by going to get a few Happy Meals for their family than by buying in a bag of apples, because the apples, they're about $1 a piece, right? And so if we recommend they do exercise, there's no guarantee that the neighborhood in which they live is safe. Is there a place for them to walk? Are there street lights in the evenings? Is the playground functional even? Asking them to travel for visits with a specialist, you have to take into consideration the transportation mechanisms. What are the routes that are available within that community? That's something that we faced, especially with vaccinations and antibody infusions for COVID-19. So how do they get there? It's one thing to say, go to this place, but how do they get there? What's going on socially that's going to allow them to get there? And depending on their employment status, they may or may not have insurance, may have to pay, if they do have insurance, they may have to pay a high deductible, which could prevent them from seeking medical care until it's too late. So by the time you get to them, they're more advanced in their illness, or their illness is not as well controlled. And so that requires more effort and again, more medical intervention, which they may not be able to do, because it goes all the way back to the social determinants issue. And with our diverse community, we have a very diverse community, especially in Queens. Language and literacy need to be taken into consideration. So a patient is likely to work with a physician if they have some commonality, or at a bare minimum, some culturally sensitive care. So you just need to do that. And that's what I have to learn to use, is to be culturally sensitive as I'm taking care of them. It's not the usual history, physical, prescription, referring you to get a lab or a test or to see a specialist. I have to figure out what's going to be the best option for each patient, taking into consideration the limitations that are brought on by those social determinants and their social vulnerability.
Thank you so much. And thank you so much for bringing up the term cultural sensitivity. Historically, there has been mistrust in the relationships between racial and ethnic minorities in the healthcare industry. And this is a question for any of the panelists. Where does this medical mistrust come from in these communities of color, and is it warranted?
I think a large part of why there's so much distrust is the fact that, unfortunately, historically, we have not really been allowed to be doctors. I think if we start with looking at that, what always amazes me is the fact that 100 years ago in the early 1900s, roughly 5% of physicians were Black. It's not much different than it is today in 2021. So if you're already saying that we can't be doctors, then that's already going to add a layer of distrust. And when I'm saying we can't be doctors, I know people are like, oh, you can just go to medical school. I'll explain to you what the barriers are, because I don't think a lot of people understand. So in the early 1900s, there was something called the Fleckner Report that was put out, where Mr. Fleckner was charged with looking for medical schools of whether they should maintain their accreditation. At that time, Black physicians were not allowed to go to med school with white physicians. They were segregated. And to make a long story short, we only had about 7 or 8 medical schools, and most of them were closed as a result. So if back then we had few options, what's going to happen now? What happens is you have generations of people who've been limited economically, educationally, and that carries on for generation to generation. So until we address some of these systemic issues that have caused some of these problems in healthcare, we're not going to even get to the tip of the iceberg of how to fix the problem for our patients.
And I'll piggyback on that, because the mistrust that you don't have the people that look like you or who are with you. So there's that mistrust. But then we also have, historically, everybody knows about the Tuskegee experiment, where you had, and for those who don't know, in the 1930s, they started this experiment. Mind you, this was government sanctioned, right? So it was the United States Public Health Service and the Centers for Disease Control. This was government sanctioned studies on sharecroppers, about 600 of them, who had syphilis, and they were studied to see what would happen as they continued with syphilis. Now, mind you, in 1947 or so, we had penicillin, which could treat syphilis. These men were not given that treatment. This study was supposed to be 6 months long. It lasted for 40 years. No treatment at all. They continued to manifest the illness, got late stage disease. They infected their spouses, and the study was it ended in 1972. 40 years later, after it had started, it ended. And these men were told that they were getting free healthcare. So they would come regularly. They were told they were getting free healthcare, but really what was happening is that they were just documenting their signs and symptoms. And they were also giving them placebos, vitamins, et cetera. So telling them that it was vitamins, it wasn't, or treatment, but it wasn't really treatment. And so if this ended in the 1970s, we know people that were living in the 1970s. They were aware. So many of us were, well, I can't say many of us, I'm older than many, but a number of us were alive during that period. And so that information is passed down from generation to generation. Did you hear that the government was giving free healthcare, but really they were experimenting on our people? And so so what they say, okay, if the government comes by again, don't pay attention to them because they're lying. They're actually going to experiment on you. So even though this is, it's been several decades later, that history is there. And the fact that it was a government sanctioned study, even when the funding ran out, they continue to do the study. And so that's kind of scary. And then of course with Henrietta Lacks, that was a movie, a woman who went in, she was diagnosed with cervical cancers, biopsies were taken, and it was used to create a cell line that led to a lot of advancements in medicine, created a multi-million-dollar industry for medicine and research. And her family never knew, she died the same year that she was diagnosed. And they found out in 1970 that it was her cell line, but they didn't tell her family till 1975. So, again, to that.
And to your point, her family had horrible healthcare issues and weren't even able to benefit from the contribution to science that their mother had made.
If I can also add to that, and I see someone actually in the comments actually mentions like the father of modern gynecology. So certainly there was some additional atrocities, for the purpose of medical advancements, right? But I also, I'm also trying to heal our communities. I don't want to necessarily reify the mistrust that they have. I completely agree with every point that's been made here. Representation matters. Our ability to, empower ourselves in the context of, medical research and clinical trials definitely matters. But, also to the point of the Tuskegee trials in 1974, following the Tuskegee incidents, and actually it was because of the outrage from from this experiment, if you will. I don't like to use that word. Like, I don't even want to justify what happened with any type of scientific, nomenclature, but following the syphilis trials at Tuskegee, there was a commission for the protection of human rights that was enacted to create something that is now the foundation of human subjects research. It's called the Belmont Report. And in order to do research at all on human subjects, and I mean, even if you're not touching them, right, just asking them questions, you have to ensure that your research is housed within the protections that are exhibited by the Belmont Report. This includes like 3 tenets. One is respect for persons, which is basically, saying that we won't be doing anything without their knowledge. Beneficence is the second tenet, which means that we have to minimize harm, and any harm that is present has to be fully disclosed, and it is up to the patient that this will not impact their treatment. For instance, if this is a clinical trial, that you will be given the proper treatment within the context of this research. But the last one is my favorite, and it's called justice. And I don't think that we really pay close enough attention to that third tenet, especially in the process of institutional review boards. Like, it's more like a liability board right now. It's really more like the institutions are trying to protect themselves more than they're trying to protect the people. And so I would say that's also some of the bias, right? That we don't necessarily, even though these protections are in place, right? So the things that happened at Tuskegee cannot ever happen again. But I do think that we haven't harnessed the fullness of the intention of the protections that have been put in place, which justice is what I'm talking about. So, this bias in access to clinical trials now, for me, is the other end of the pendulum. So on one end, it's like, we can't get access to medical research unless you can abuse us. But now that the protections are in place, all of a sudden you can't find us and we don't participate. Some of that is certainly well-deserved mistrust, but other parts of it are really, founded in the fact that these institutions that I work for, that we work for, don't really do our due diligence to make sure that, the research that can actually benefit these populations gets to them. And I'll get off my little
And can I just add one? Can I just add one piggyback to what something Dr. Tochi said about Tuskegee not being that long ago? Also, Dr. Tochi, the last living survivor, Ernest Hendren, just died in 2004. So not only for those of us who were around in the 70s, but for those of us who were younger, there's no reason why we shouldn't know if he just died about 16, 17 years ago.
Absolutely. Thank you all so much for the information, for the insight, for the history. And it's so funny, Dr. Davis, that you brought up IRBs, institutional review boards, and human research protection programs. A few weeks back, the BERG hosted a coffee conversation where we had experts from the Feinstein Institutes really do a deep dive in what exactly are those programs, what are they designed to do, and not only that, but the diversity and who we have here at Northwell who are part of those teams, because that is information that a lot of people, I'm guilty of it myself. Outside of the people that I work with through the Business Employee Resource Group, I didn't have as much in-depth knowledge around the IRB until we did that event. So I'm so glad that you brought that up. And for anyone on the tech team, if you're able to grab the YouTube link so that way our attendees can watch the playback of that video at a later time, please post that in the chat so that way our viewers have that. And I'm glad we brought up clinical trials. We will get to that in just a second because it's certainly relevant to COVID and a lot of the conversations that we've been having. But what I love about this panel is that we have experts in different specialties. So Dr. Myers, let's kick it over to you to talk a little bit about diabetes in the Black community, because I know you've done extensive work in this space. These are the patients that you're seeing on a day-to-day basis. So let's kind of run some stats for our viewers. Blacks are 80% more likely to be diagnosed with diabetes, 2.4 times more likely to begin treatment for end-stage renal disease. What do you think leads to the disparities in diabetes, and what do you think could help close that gap?
Oh, absolutely. A great question. So I think when you think about what leads to the disparities of diabetes in our community, it's a very difficult question to answer because there's so many layers involved. There's not one particular thing. So obviously we know genetics. You can't get away from your genetics. A lot of us, unfortunately, have longstanding family history. I can tell you in my family, my father has diabetes. Multiple of his cousins had it. On my mother's side, both of my grandparents had diabetes. So, you know, unfortunately, we have a genetic predisposition, and currently about 11.7% of the people who have diabetes in this country, and there's roughly 30 million people with diabetes in the United States, are us. So not only is it our genetics, but there's also a lot of the socioeconomic factors that Dr. Tochi brought up earlier. If you live in areas where there are food deserts, or if you're on a limited income, it's a lot easier to get things that are made with high fructose corn syrup, things that are processed. So if you're eating a lot of that processed type of food or drinking a lot of those processed drinks and sodas, you're going to get belly fat. And belly fat is definitely going to predispose you to having diabetes. We also know that there are differences in care. Unfortunately, as someone I saw put in the chat, when you have better health insurance, you get better access to doctors and care. One of the best programs that has been proven is the DPP, that's the Diabetes Prevention Program, because one of the things we want to do is we want to get people before we get to diabetes. But that program was sponsored, and the study showed that if you lose 5 to 10% of your body weight, roughly 58% of those people who did this lifestyle modification were able to get rid of their diabetes. The thing is this program was done through the YMCA and a certain other community areas, but are these in areas that where our people live, where they have access, going back to, again, what Dr. Tochi brought up about access to care, are they going to have access to these resources to get these programs? And I think, you know, those are just some of the things that need to happen if we really want to assess how we can improve diabetes care in our community. And going back to the previous point I made, we also need more providers. And it's the same thing with, you can see with Dr. Janna, we're unicorns. Subspecialists in internal medicine, we're very hard to find. And it's very difficult to see the statistic, but when I looked it up, only about 0.03% of endocrinologists, according to an AMA study, are Black. So I know there's one other doctor in the area who looks like me, but there are very few. And there are very few Latino or Latina as well, endocrinologists, but we are the ones who carry the burden of this disease because 12.5% of our Hispanic brothers and sisters are dealing with diabetes as well. So part of it is we have to get more people going into diabetes, more people doing research. You mentioned earlier about more of us having end-stage renal disease. We are also more likely to have amputations. We are 3.2 times more likely to have our limbs amputated when we have something that starts a small ulcer and it gets worse. And guess what? If you look at NIH funding, you find nothing in that area. So not only do we need more researchers, but we also need to get the funding and the interest from the powers that be to pay for research in these areas. And those are some of the basic things that we can do. And one last thing I would also mention is diabetes technology. So we have insulin pumps, sensors. I love these things because it helps so many people get better control of their diabetes. But if you look at studies time and time again, our people are the ones less likely to use them. And sometimes it may just be we don't want to use it, but very often it's that our people don't know because they're not seeing providers that are actually talking to them about using it. I've talked to all my patients. It doesn't matter, you're white, Black, Asian, Hispanic. I talk to all my patients because I want good care for everybody, but unfortunately, we don't always find that in medicine.
Wow, thank you so much, Dr. Myers. I always enjoy listening to you speak to the work that you do because it's always new information that I'm gaining and learning, especially around these health challenges that are so prevalent in our communities. Dr. Roswell, I would love to call you to the front because, you know, with your specialty and along those same lines in terms of heart health, Black men are 30% and women 60% more likely to have high blood pressure. Men have twice the risk of first-time stroke. How do you see these disparities that we've been discussing so far playing out in your patient population?
Yeah, they're alarming, but I want to step back a little bit about what we're talking about, because a lot of we're talking about social determinants of health, we're talking about socioeconomic status, we're talking about the pathway of people, but I think we need to go back a little bit further to name it. And all of this is structural racism. We talked about systemic racism and structural racism. They're interchangeable, but structural racism is not one person who was organizing something. These are policies, these are cultural norms, these are the ways that social determinants of health that impact people negatively, that's the way they form. So when you talk about limiting access to education or healthcare or neighborhoods, getting a car loan, getting a home loan, putting that all into policy, having residential segregation, all of those are sort of structural factors. And so, and I think this is something that we need to emphasize here. When you're talking about structural racism, you're not talking about one person, but you're talking about how these policies bring to bear disparate outcomes in certain communities. And when you're talking about, again, education, when you're talking about the criminal justice system, everything that we're talking about that impacts health it has a basis of structural racism. And so to be anti-racist is actually realizing that and realizing that there's all of these policies and procedures where you may think that they're just normal because it's the way we've been accustomed, but it's actually reproducing a lot of these healthcare disparities over and over. And we term that into the social determinants of health, because that's what actually determines our health is all of these social factors. But we always have to go back and figure out, why are the social factors that way? They just didn't pop up where, you know, Hispanics and Black have higher rates of diabetes, et cetera. It's because of what Dr. Iroku was talking about. Is talking about food deserts. It's talking about how people can afford to buy food. How are they educated? Those are the reasons that all of these things are happening. So I just wanted us to take a quick step back just to ground this conversation in structural racism and how it affects all of these different health outcomes, because I think that's critically important. And I think it's a more abstract concept that people are starting to talk about, but I wanted to make sure our guests here understand what that actually means. And parts of structural racism are actually individual or interpersonal racism. That's a part of it. And when you talk about the disparities in hypertension that you've seen in Black and also Hispanic, you have to think about it. Just look at the Black people all over the world. Black people in Africa and in Europe, they don't have high rates of hypertension, but Black people in America do. And so you have to think about what's specific about America in terms of Black people in America that's causing high rates of hypertension and stroke. And so there's been a lot of research on this, and a lot of it is associated with discrimination. So there's something called the Everyday Discrimination Scale, and David R. Williams has published this numerous times. There are a lot of other people who publish this, and they really go to Black and Hispanics and ask them, how do you perceive yourself in this country? Are you being discriminated on a daily basis? And the answer was yes, much more so than any other group. But what they found is that level of discrimination actually got blood pressures higher. They actually got increase in cortisol, which is what Dr. Myers is talking about, which is visceral fat, which will be a predisposition for diabetes. They talked about actually having coronary calcifications. And I talked about this before, but that's a precursor, that's premature atherosclerosis, and that's coronary artery disease. So actually, if you think about it, the stress that people have from discrimination, everyday discrimination, are associated with hypertension, diabetes, et cetera. So if you ask me, why are Blacks have a disproportionate sort of incidence of diabetes, hypertension, and also strokes, I would say structural racism and racism. So going to those social determinants of health and figuring out why they are, but also the racism that causes the daily stress in people's lives. And that's, I think, is a great explanation of why we're seeing these disparate outcomes. And I think to solve them, we always have to go back to the beginning and figure that out. And we have to get more people in medicine. We have to fix our educational system. But you see why we need allies, because structural racism, systemic racism, however you term it, it's permeated. It's in the DNA of our society. So we need everyone to realize it and do their part to sort of work and figure out how to fix this as a team. Because there's no way that I could do it alone, or you could do it alone, or anyone on this panel could do it alone. We as a country need to do it together. And I think that's the call that we should move towards.
Absolutely, Dr. Roswell. And, Dr. Davis, I can imagine that, with everything that Dr. Myers and Dr. Roswell recently shared, in terms of cancer and the work that you're doing, women are 40% more likely to die of breast cancer. Men are 1.3 times more likely to have new cases of colorectal cancer. Can you touch on what your research has demonstrated in terms of why these numbers are where they at? Are they similar to a lot of the sentiments that Dr. Roswell just shared with us?
So yes, absolutely. I think that, from an oncologic anthropological perspective, so we actually do global research, right? So one of the things that we sort of uncover when we actually spend a significant amount of time in African nations as well, for my center. And so one of the things that we find, for instance, is, there are some things that tend to look like they are associated with ancestry. And we see that, sort of traverse the whole diaspora for certain subtypes of breast cancer, for instance, and certain, presentations of prostate cancer even. But then there are also these anomalies in the tumor biology, right? So I do genomics research, and one of the things that we look for are opportunities to create targeted therapies that would benefit this population. Now, I understand that, these are multifaceted issues, right? So even if I find the treatment for the type of cancer most African Americans get tomorrow, will it actually get to them? Will they be able to get to it? Is often an issue. But I would say that, yes, there's a part of every experience an individual has that feeds into their risk, right? They're sort of mediators of risk, right? So I'm looking at genetic susceptibility, and even the genetic susceptibility is somehow masked in this population, primarily because the data that is the evidence that stands up the clinical tests for instance, breast cancer mutations, are largely built upon data from people of European ancestry. So for instance, the statistics right now show that if a Black woman gets a, BRCA test or a mutation panel test, if the report comes back with a mutation, 40% of the time it's going to be a variant of unknown significance, which is unactionable. So it's like, well, we see a mutation in this cancer gene, but we don't really know what this mutation is because we've never seen it before. Well, maybe that's not true. Maybe we've seen it a dozen times in the last year and they're all in African Americans, but because we haven't done any additional research to define what these mutations are, we continuously have nothing to give you, in terms of prevention or even treatment. And so, that's one issue, that we really need to have more diversity in the data to fully understand what the susceptibilities are. And then secondly, more recently, we haven't even published this yet, but I can see an imprint of diabetes and obesity in the tumors of African American women when I compare them to the tumors of Caucasian women, even in Africa, right? If I compare African Americans to Africans, I can see a signature of the impact of social determinants in their tumor biology. And I would like I would like my communities to understand that, like not only may we have, because we're not sure really, but may we have a unique susceptibility to cancers. Maybe it's the same susceptibility, but we just don't know how to define it yet. But more importantly, what you eat, it matters, right? How you make choices, even in the challenged environment, that you live in. You need to, do what you can, however you can, to make sure that you make, you make better choices. And so, yes, systemic racism has this insidious way of impacting every aspect of our lives, our development, our ability to fight disease, our ability to get access to the treatment, that could be curative. And so I can only do one thing at a time, you know what I mean? So as a geneticist, I try to focus on the genes, but inevitably, you know, I have to address all of these things on some level, which is why I'm here today, right? And I think that as a community of professionals, not only does our representation matter, but our passion, you know, also matters, because until, you know, there's some action that, you know, alleviates some of the systemic racism, we'll continue to see disparities.
Thank you so much, Dr. Davis. As a radiation oncologist, everything that you said truly resonates with me. And I think what you also touched upon earlier was that when we're looking at these treatments, all the research has been based on majority white patient populations, and we're assuming that one size fits all. Let's move this discussion along. I think that this has been very enlightening, but let's talk about COVID. Let's talk about the Black and brown community and COVID, and how shocking or shocked the media was that Black and brown communities seem to be so disproportionately impacted by COVID. So we've already discussed about the social determinants of health and the groundwork that racism has laid to lead to this moment. Dr. Iroku, I'd like to come back to you. You know, why do you think Blacks are more disproportionately affected by COVID? I mean, we can go back to housing, unemployment. You know, I would love to get your thoughts on what makes Black and brown people more vulnerable in this situation.
So with our history of the inequities that we have in terms of accessing healthcare, remember I mentioned how we try to get preventive care so that you're healthier, and that we address your illnesses or your conditions quickly. We have these impacts of stress, as was mentioned by Dr. Roswell. And then also, what was not mentioned is, you know, this also affects our maternal mortality, right? Maternal mortality and morbidity is because there's that link to stress, that extra added daily stress that Black women have, which impacts the way they carry their pregnancies and then their outcomes. Then we have implicit bias and outright bias when they come for medical treatment. And then you have the mistrust of the healthcare systems, and you have mistrust of government issues. So and then the public health systems were not adequately structured. The financing or the funding of public health was not as adequate as it should have been for a country as wealthy as ours, the United States. And even when things were funded, it was disproportionately funded. So those areas that had the Black and brown communities may not have gotten the same or significant amount of funding to address their needs, public health needs. So you have a pandemic that arrives, and you have people that have not had preventive care, that have longstanding illnesses, have high levels of stress due to racism in all its forms, shapes, and sizes, social determinants of health that are affecting them. Then of course you come in with this new illness, it's going to hit the vulnerable. And that's where that, you know, the vulnerability index takes a role, right? Plays a role. You know, you have a situation where something that was devastating came in, and if your foundation was strong, you're better able to withstand it. But for this population, their foundation was very weak. And so when this came along, when COVID came along, it just laid it bare. You know, you say, okay, let's quickly, how do we galvanize everyone? How do we take care of them? Well, how do you get to these people that you've not really put into place a structure by which to take care of them, or to gain access to them, or for them to come to you? All of that has been in, you know, disarray for so long that all of a sudden an emergency comes, you're unable to take care of that. I mean, that's that vulnerability index that, you know, I spoke of earlier. I mean, and that index is based on, you know, whether, you know, it's poverty level, housing, you know, language barriers, et cetera. And it's a scale of 0 to 1. 0 is, you know, you're good to go. 1 is a higher issue. Suffolk County, Nassau County, we're about a 0.25, 0.3. The Bronx, 0.99, right? So think about that. So that means that in an emergency, whether it's a natural disaster or a pandemic, accessing that community and being able to take care of them, we don't have the structure in place to take care of them. And that's why COVID came and really showed us what was wrong. We had not built a good foundation for those communities.
I would just jump in really quickly, and I'm going to sound like a broken record really quickly, is that we have to think about why aren't those communities built that way, right? And you could just think about, years ago, decades ago, when people are creating neighborhoods and policies and educational policies, perhaps the people around the table were saying, I live in this community, why don't we have the property taxes that we pay build the educational centers for this community? It sounds really good, but what happens to the community then that's next to you, that it's a low income community? You've already, just by that simple decision, you've already set up a structure where one community is educated, may have resources, and then the other one doesn't. And I think this is I think very critical, that it's so easy just to put in a policy and not think about how it affects other people. And then the pandemic comes, and then you realize people who have, really high social vulnerability index, like those are the ones that are getting sort of higher mortality. And then everyone steps back and says, well, why is this happening? And this is happening, quite frankly, from those decision points where you decide to make these neighborhoods and give them more resources without thinking about what you're doing to the other neighborhoods. And when you're not spreading the resources equitably, then you have disparities in education and everything else, and it spills into healthcare disparities. And so I'm always going to ground us back whenever we're talking about stuff to why it is that way. And I think that's important because we as a community have to try and fix it.
And I would add, even right here in Queens, it was pretty rough over here. So I can tell you, people from my neighborhood traveled to LIJ and North Shore because Elmhurst Hospital had no beds. You literally saw people in the street, down the block, around the corner, waiting to get tested. And because they were so full, they told people, I'm sorry, you have to go home. My neighbor, who's elderly, has diabetes, he was told, I'm sorry, we don't have any space for you. You'll have to go home and quarantine. We just don't have the resources. People over here were quite stretched. I can tell you, the supermarket, line out the door. Instacart, forget it. Instacart wasn't coming over here. I remember when Northwell sent around for Baldor Foods, one of my colleagues who works in Massapequa, he got a delivery. Over here, they were like, well, if you want a delivery, you can come out to Huntington. So as someone who lives in the community, I can speak that it was really devastating. I may have a nice salary as a physician, but a lot of people around me do not have that. So I can get in my car and drive to Long Island and get things for my family. But a lot of people around here don't have those resources. And that's why it was so easy for COVID to disseminate amongst these types of areas.
And just to let you know, the Queen's Social Vulnerability Index, 0.63. So it was a thing waiting to happen, a big problem waiting to happen.
Absolutely.
Thank you so much for pointing that out. Going back to the one size fits all, the first part of the question I want to address to Dr. Davis, but the second part of the question I want any of you to jump in. I'm curious to see what you think. But the CDC released guidelines about the symptoms associated with COVID. And Dr. Davis, I know you've actually done some research on this work. Can you explain how all symptoms might not apply equally to all racial or ancestral groups, number one? And then along the same lines, we've known for a long time that pulse oximeters actually can give, erroneous oxygen levels in people of color. So does this mean that the tools that were used to diagnose Blacks were less accurate for the Black community or communities of color compared to white patients?
Right. So to address your first question, of course, the research that I do has a lot to do with genetic ancestry, in the sense that there are certain biological systems, like the immune system, for instance, that because of our ancestry can be very distinct. And so my research was actually started out in breast cancer, some of the things I just described, where we're looking at tumor biology, but we're also looking at systemic host response. So there's an ancestral marker that affects systemic inflammation. It's called the Duffy null allele. And so that's sort of, the funded project that I work on is really focused on trying to identify whether or not this allele can impact the disease trajectory of COVID-19. So it's already been shown that it impacts other lung injuries, so pneumonia, for instance. And so it made sense to me that some of the severity we might see in certain populations with higher proportions of African ancestry may also be suffering severe disease. And so all of that to say, for instance, even I'm sorry, I'm gonna get flustered because there's just so much rushing in my head right now. I wanna say it all at once, but I think that first of all, so yes, presentation of, symptoms in the midst of the peak, we really weren't certain, right? Like what the actual presentation of the disease was going to be. It was different across different populations. It was different depending on not just race, but also your comorbidities. So what our research is starting to show is that some of the risk factors, for instance, that are associated with whether or not you had mild symptoms or severe symptoms, or after severe symptoms, if you died or if you recovered, had a lot to do with your clinical status. And some of that and some of that even indicates that above and beyond where you live, because that's how we actually assess social determinants, right? So this vulnerability factor, we translated that into a neighborhood deprivation index, right? So in our research, we paid attention to the neighborhoods where patients lived, and that was sort of the social determinant piece of our multivariate model. And what we found was, regardless of your neighborhood deprivation, that impacted whether you got the disease, whether you got infected. But once you had it, what really impacted whether or not you survived or had severe symptoms was whether or not you already had hypertension, if you were a diabetic, if you were obese, for instance. And so then presentation at the time of the peak was variant across the general public because they weren't necessarily accounting for things like, comorbidities. And so we would hear stories, for instance, in our multi-hospital system, where the patients who were showing up, for instance, in Queens and Brooklyn, were being turned away because they didn't have the right constellation of symptoms, right? Like they didn't have a severe fever, but they were short of breath. And so, like you pointed out, the O2 readings showed and indicated that, they were within a safe range to go home, but then they never left home again until they died, and so, and so how do you actually, remedy something like that? I think it's a very complicated question. But then now we see, for instance, all of the prioritization around immunization is sort of contextualized in what we anticipated was the risk factors for death. So, elderly individuals who are in a certain race group are more impacted by age than others. And the only way I can describe this in another way is that, age wasn't necessarily the main risk factor in the African American population. When we look back at who died from COVID during the peak, age wasn't the most significant risk factor for African Americans. Diabetes was. And so maybe in the prioritization of immunization, having diabetes should have been just as important as immunizing, the elderly. And, it breaks my heart because I think that it's almost too late, to go back and say, well, we need to also cover certain comorbidities. And, again, this is sort of that disparity where the research that was rolling out in the beginning about risk factors largely included only whites, or it didn't stratify for race at all. And so we really didn't pay attention to the fact that there were different factors in specific populations associated with worse outcomes.
Dr. Myers, you want to jump on that?
Yeah, I was going to actually bring up something in reference to your point, Dr. Davis. So a lot of people in the chat have been talking about Harriet Washington, and she actually has a new book out called Carte Blanche, The Erosion of Medical Consent. And yesterday she did a wonderful panel with Jelani Cobb. And one of the things she brought up that I thought was so interesting, speaking to your point about age, is she said that our people tend to die at a younger age. So that already going back to this point that Dr. Roswell was making, we have to keep bringing it back to systemic racism. That alone in itself put us at a disadvantage because you find more of the other folks living to be at 90 and 100 and being over 75 when you compare it to us and other ethnic minorities. So that was the only point I just wanted to add.
And even on top of that, just one more thing, I promise is about the last point. So, redlining in Manhattan, there was a recent study that showed, for instance, life expectancy just blocks away right here in one borough, right? That the people who live in the Upper East Side have like a 30-year longer life expectancy than individuals who lived in other parts of the borough. So you're talking about we're going to vaccinate the oldest people in the community. You're systematic racism. You're systematically, marginalizing the survival of the community that you already said had the highest incidence and the highest death rate of the disease. And now I'm going to lower my voice. Calm down.
Thank you also. Go ahead, Dr. Roswell.
Really quickly, because I think these are great points. And there's a lot of literature looking at, let's say, education levels and age and survival. But if you look at the data, you see that there is about a 7-year gap between, let's say, a white person who's college educated versus not. And they live longer because they can acquire more resources, et cetera. For Black people, that curve has shifted so much downstream that even for the same amount of education, a Black person who's college educated lives less years than a white person who is not college educated. And so we see how things impact, lifespan and survival and mortality. But there's this X factor, which we'll name it again because we're talking about it. Racism really has its ways of limiting lifespan. And these are, I think, data that we have to all be accustomed to and talk about because they're really important. This is the only way we're going to sort of make a dent in what's going on, because all of this is affecting lifespan and survival.
Absolutely. Thank you all so much. And, when we think about data and when we arrived to this point in time when the vaccine became available and the big conversation became, well, Black communities aren't rushing to be vaccinated and let's push out information. And while we're at it, let's push out more information. And of course, we know that's important, right? To ensure that all communities understand exactly what is the vaccine, what does it do, how does it work? And Dr. Myers and Dr. Williams, who's also on, have been doing tremendous work, as well as all of you in your respective spaces. But from my experience, and of course, being a non-clinical person, when being a part of different conversations around vaccine education and what that means, for the Bridgesburg, it was so important to really talk about the things that were not being talked about during those education meetings, right? So for example, talking about human resource protection programs, making sure that any type of marketing information that's being created is being translated appropriately and accurately and efficiently before it gets distributed into diverse communities. So I would love for us to kind of shift a little bit to that reluctancy in the Black community to take the vaccine, and maybe hear, from maybe one or two of you, some of the concerns that you've been hearing from your patients and how you've been advising them and guiding them to make informed decisions as to whether or not they should or should not get the vaccine.
I think that I had a slide. I don't know if it can be shown here. So this is, and this was basically just showing vaccine hesitancy at the beginning of the when the vaccine first came out. I don't know, I haven't seen this slide yet, but but it shows up.
Yes, tech team is pulling it up now for you.
Okay, great. So it's basically that we, at the beginning, when the vaccine first came out, because of that mistrust that was built in, which we've been speaking about, when we go back to Dr. Roswell's, systemic racism, institutional racism, even the individual racism that you have within the medical community, people were very hesitant. It's funny, a lot of people were hesitant, but if you broke it down by ethnicity and race, the Black population was the most hesitant. So I think, I don't know if I can see that. So yeah, but the Black community was the most hesitant group to I don't see the slide, but anyway. Oh, okay. Okay. So that's okay. So basically, what it is that when it came to the different I'm sorry. Can you hear me?
Yeah, I'm sorry. I was saying I think we're
That
just
was
having
it.
difficulty sharing the screen, but it's coming.
Okay, there you go. So you can hear, you can all hear moping. So, right, the Graduate School of Public Health, they were tracking this vaccine acceptance by race and ethnicity, and when the vaccine, for September to January. So that's when they ended it in January, end of January this year. And you can see for the Black community, the acceptance rate was only like a third that people of Blacks that said that they would take it. For Latinos and the Latinx community, whites, they were about 50%. Remember, there were a lot of people that were kind of cautious about it, and then the Asian community was 83%. Fast forward as things progressed, and of course, we started hearing about variants, and we saw how many people were getting the vaccine, and there were education that went out. There's been an uptick, except for the Asian community. There's been an uptick in the vaccine acceptance. However, the Black community and Latinx community still lags behind the white community and the Asian community. And so you have to now say, okay, this community, how do we reach out to them and say that this is important? You'll notice that with social media, with TV ads, etc., you have people that are, people that represent Blacks and Latinxes, they're showing that they've gotten the vaccine to try and to encourage the members of their community to get the vaccine, to show that it's important to do it for themselves and to do it for their loved ones, for their families and friends, and to get back to some sort of new normal. Again, but there's that tug of war within the mind. It's like, okay, yes, you guys want me to get this because you know that I am one of those people that may be greatly affected by this illness, but at the same time, you're coming to me and you're telling me it's free. And then you have that backside, you're in the back of your mind, you're saying, why are you giving me this free stuff? And you're telling me it's made by this new mechanism, mRNA. Are you experimenting on me? So that's the tug of war that's playing in. And so you have to say, okay, and then people are aggressively trying to pursue the communities that are underserved. Whereas before, you're saying, well, you didn't need me before. Now all of a sudden you want me and you want to give me this new preventative measure. So that's what it is. So what I'm doing with my population is just basically listening to them, hearing them out, whatever their fears are, addressing their concerns, telling them the truth, the facts that I have, and the things that are unknown. I am very transparent, and I tell them it's unknown, that I do not know what, there are certain things we do not know yet. And as time progresses, we'll find out what's going on. I know that ACOG issued out this, that they wanted their pregnant patients to get vaccinated because a pregnant woman who has COVID has a higher risk of having complications, hospitalization, and worse outcomes than if she doesn't have COVID. So it's better for her to have the vaccine. And so stating these things, saying that this is what we know today, this is how we'll help you. The one thing we know about the vaccines is that regardless of which type it is, it will prevent you, it will help to decrease your chance of being hospitalized with this illness. And hospitalization can also lead to death. Washing of hands, adding this to your toolkit, help you stay safe, is important. And you listen to them. You don't berate them. You don't shame them. You hear them validate their concerns and say, we'll continue to discuss this at the next visit. And at the next visit, you bring it up again. You're at high risk. You have an opportunity to get this vaccine. What are your concerns? Is this something you're willing to do today? And then you take it from there. Just gently and answering the questions and having forums where they're allowed to express their fear.
Thank you so much, Dr. Iroku. And we'll have one more before we turn it over to audience Q&A.
So I just wanted to add in really quickly about the vaccine and perhaps vaccine hesitancy, but I think it's also vaccine access. And I think when you're looking at the data, the data show probably a level of vaccine hesitancy, which is well founded in the Black and Hispanic community, but there's also vaccine access. And we know, as we've been trying to arrange our loved ones who are elderly, trying to arrange these vaccine appointments on websites, and you really have to have first fast Wi-Fi, you have to be really agile, and you have to have an email address. And I can tell you for my particular family, the ones when we had serious conversations about it, when they decided to agree, my aunt who's 80 and who came here from Guyana does not have an email address. And they decided to have a family one where they would share it. And guess what? You only could have one vaccine per email address. So then we had to try and register other people. And so there was a lot of differences in terms of access, how fast you can get your Wi-Fi and your tech savviness to actually get the vaccine. And then there were people who were like, you know what? I really just want to wait and see. I may want it, but maybe I want it in a couple of months or not. I don't want to be on the first wave. And there are people who are like really homeopathic, like I don't take vaccines ever. And so why would I do this one? And so I just bring that up for different perspectives of why people don't want to take the vaccine. But I do think hesitancy is a big slice of that, but then there are also other things involved. And I think once a couple of people, let's say for my family, started getting it, my aunt, then they started going as pods. They called their friends and they all went together. And we were working in South Brooklyn in Canarsie, and we got all when the pods started forming, they called their friends, they all went down to the church together and all got vaccinated. And so I was very happy to see that sort of thing happening and being able to report it back that the message is spreading throughout the community, and we have to keep on spreading the message. And I think more people will get it, and we will get and erase a little bit more of the hesitancy. So just to offer that other perspective.
Absolutely. No, thank you for that, Dr. Roswell. It's funny because I can remember a few months back at church, my pastor was certainly a part of the group of saying, I don't get the vaccine and I don't get vaccinated for any reasons. And just this past Sunday, he was showing his Band-Aid from when he got his second dose of Pfizer on Saturday. So I certainly know that many of us have probably seen similar behaviors in our communities. So at this time, I will turn it over to our Bridges Tech team who has been monitoring the chat to ask some of the questions for the panelists that have been coming in during this discussion.
Thank you, Andrea. And thank you everyone for submitting your questions. We received a lot of great questions here, but I think we have time for two. So the first question for the panel comes from Jeanette Gonzalez. She asks, do you think it would ever be possible for all of us to be identified as the human race instead of identifying every individual according to ethnicity? What are your thoughts?
I'm going to say, I don't believe in this lifetime because remember, well, I'm not going to say remember, understand that it's not just in the United States that this exists. So this whole issue about disparities and ethnic issues and racism occurs in many countries all around the world. And so even if in the United States we were able to get to a point where we felt we were the human race, the rest of the world, I don't believe yet, and we are currently not there. So I don't know if we are going to get in our lifetime. I do believe that newer generation hopefully are more socially conscious and are willing to acknowledge. See, we don't want to count the difference, we want to acknowledge the differences and accept them. So it's important to have everybody have their uniqueness, and it's good to be able to identify with a group that you belong to. So that's great. But just having respect, I would say that maybe will we eventually have respect? I'm hoping that in the future we'll have a majority of us around the world having respect, because we are influenced by not just what happens in our community or in our country, but by what happens internationally. So if we can have greater respect for others who are different than us, whether it's biologically or physically or genetically, if we have that respect, I think we can then hopefully we'll get there. Majority. You will. I don't know. You will get 100%, but majority.
I just wanted to chime in. Oh, sorry. Go ahead, Dr. Davis.
I was just going to agree actually and say that, I get that kind of question a lot, especially as a geneticist. I often hear people say that race doesn't correlate with genetics or ancestry. And actually it does to some degree. I think that, back to the first question of weaponizing race, I think we need to get away from thinking that race is a bad thing. Race isn't the issue. Racism is the issue. And to Dr. Tochi's point, I believe that the issue needs to be addressed head on. That the diversity that exists in the human race is something of beauty. And I don't think that we need to strip people of their identities in order to normalize, who we all are. I think that to the contrary, that we need to understand, who we are and who we identify as. I think that's beautiful. And I would shudder to think that all of a sudden we would just, erase the diversity and pretend to be colorblind, just for the sake of getting along when we could just appreciate, the differences.
Yeah, I agree. I think the only thing I was going to add is that it seems instead of us moving towards a one peaceful society, it just seems like at this particular time, there's just so much violence and hatred. And I think it just bringing up all the anti-Asian racism and all the violence that's been going on. And just to note that we really have to understand and love one another and really come to a place that Dr. Tochi is talking about where we could not think about race or ethnicity, et cetera. But I think what will tell us when we reach that point is when we don't have healthcare disparities, when things are a little bit more even across the nation in terms of healthcare outcomes and education and access, then I think these things are less of questions. But I think for right now, seeing what's going on, I think it's still important.
I think it's also the everyday when we all of us can get in our car and drive without getting pulled over and racially profiled, where we can go to the store and go shopping and not be followed around because someone thinks we're trying to steal from them. When all the little basic things that other ethnic groups can do without being harassed can happen to us as a people, then I think we can have that conversation.
Thank you all. We have time for one more question. This is from Nigel Walters. She asks, how does racism or unconscious bias of staff members directly or indirectly affect care of patients and their families?
I'm going to start again. So unconscious bias towards the staff members, I guess you're saying, is that what it is? Or coming from the staff members? Well, I'll do both ways. If it's aimed towards, like those of us on the panel, right? Do you have that layer of stress that you're dealing with? That makes it hard to do your job. You pull up everything you've got and so you say coming from the healthcare providers. How does it affect patients? Oh, then you're aggravating the situation. You're aggravating the stress. You're not the unconscious bias by healthcare providers means that the patients are not getting the correct treatment, because if a patient is not heard, you do not know exactly what's going on with them. If they're not validated, if they're dismissed or there's condensation, you're not going to do everything that you could for that patient. And so I think of that woman, the family physician that died, that did that video before she passed away about the treatment that she had. And what's sad is that it's, for a lot of Black women or Black female physicians who have been in the hospital or hospitalized or have been patients, I myself have went through exactly the same thing she went through. So it was sad. It was just very sad. So that bias prevents the patient from forming a trusted bond with the clinician or the provider. Therefore, following your instructions is less likely to happen. And therefore, even seeking care in the future, there are appointments where I've canceled because I knew that the provider was biased, and there was just no way I'm going to do that. I'm not going to go. Luckily, I'm a doctor. I can take care of my, but what about the rest of the community? So that's what it erodes the ability for the patients to trust the healthcare community and access the care that they need. And it may also lead to erroneous treatments that lead to unnecessary deaths or morbidities. That's what happens when you have unconscious bias in the healthcare system.
And just really quickly, I think the dangerous thing with unconscious bias is the provider who's delivering the healthcare may not be aware of what they're doing. And this is where it's really important to sort of pause and check yourself in terms of biases. But if you withhold a procedure or a medication or a referral for a patient and you were supposed to, the question is who's checking that? And that's what the hospital systems in terms of building equity are trying to do, because you as the provider may not have even realized what you have just done. And so that's the dangerous part of it all.
Absolutely. Wow. So to all of our attendees, thank you all so much. Please continue to share your thoughts and your questions. Our Bridges BERG leaders are capturing that information, and we'll certainly continue the conversation with our expert panelists that have spent this evening with us. I mean, I don't know about all of you, but this conversation has just been powerful, insightful. I was over here looking down, taking notes, but trying not to take my attention away from the screen for too long. You know, a lot of times, and certainly over the past several months or even the past year, participating in these types of conversations, there's so much information, you know, there's so much to take away from these conversations. And people can feel pretty overwhelmed, right? Overwhelmed with it all, unsure of what to do next. And so just keeping in mind the time, I would love to go around the panelists, and I'll call on each of you individually. What are some actionable next steps that you would empower our viewers to take to help mitigate bias in healthcare and fight against racism in healthcare? Dr. Myers, we'll start with you.
So I'm a big proponent of expanding the pipeline. So what that means is, for many of us, we were the first ones in our families to become doctors. So for those of you who are saying, what can I do to be an ally? If you are in a lab, take a Black or Hispanic young person. If you are a doctor, take someone to help you shadow. So this way they can get the experience that they need so that they can apply to medical school one day. And one last point I would like to make is there's a great documentary, if you want to know more, called Black Men in White Coats. And it speaks to a lot of the things that Dr. Iroku, Dr. Roswell, Dr. Davis, and I have talked about in terms of some of the barriers and pitfalls that we as our community have tried to overcome in order to be physicians. Thank you.
Thank you so much, Dr. Myers. And shameless plug, we're actually partnering with Dr. Roswell and team. So for all of our BERG members, you will be getting some additional information. And you know what? With that, we'll tag Dr. Roswell in for his last words.
Thanks. Yes, we will be doing that. We'll be showing that movie. Is very powerful. I think, as I was talking a lot about structural racism and we were just talking about implicit bias, I think it's really important as a team, wherever you see a policy or a procedure, I think it's critically important to interrogate that. Because we, as I said, we are not in all places at all times. You will be in charge of making a decision or something that's going to affect someone's outcome. And so you as a leader in charge of someone's life or an administrator or a healthcare provider, I think it's really important to pause, take a minute. Is this implicit bias that will be affecting this person? Or if you're writing a policy, is this an equitable policy? Or the policies that we follow, are they equitable? Should we change that? And so I would like to empower people to actually disentangle structural racism wherever you see it. I think that we're all understanding the concept. And thanks for inviting me to participate.
Absolutely, thank you. Next, we'll turn it over to you, Dr. Davis.
I think that I will probably, overlap with the last two comments, which is, the power of inclusion. So what does that actually mean day to day for the people, in the community, in the profession? I think, ask for the data, pay attention to the diversity. I am the one in the audience at all of the seminars asking, so is there diversity? What's the diversity in this panel? What's the diversity in your data? Do you know? Did you pay attention to that? I think that we have to be ever conscious, right, of whether or not we're even paying attention to the fact that some of the data, right, that is the evidence for our evidence-based medicine is not really fully vetted in all the populations that it should be. And then also I would add, ask questions, ask for the data. So anything that's race-based, that I hear about, I'm always saying, well, what's the work, behind, we making this comment, like why is this, in place? What are the actual, studies that are in place that led to, whatever the oximeter, alterations are, or, whatever is race-based, let's really take a step back and look at whether or not we need to reassess and get better
Absolutely.
information.
Thank you, Dr. Davis. And of course, last but certainly never least, Dr. Iroku-Malize.
So everything that my colleagues have said, and then two things: get educated on the topic, right? We none of us are masters of this. We are all learning, right? All of us, even those of us on the panel. So get educated, learn more about it. And if you want to learn how to be an ally, learn more about how to be an ally. That's the education piece. The second piece, advocacy. You must learn to advocate, whether it's at the local level, at the community level, the county level, the state level, or the national level. Go and make sure you can help change the laws that lead to the guidelines and policies that are made in your community. So these are two things: get educated and start doing some advocacy work.
Oh, love that. Thank you all. Thank you all so much. Thank you to all of our participants. Thank you to the African American Caribbean Bridgesburg co-chairs for extending the invitation for me to be the non-clinical person a part of this discussion. I was a little intimidated initially, but you all have just been beyond phenomenal. We talked about building a pipeline, no matter what your respective role is in healthcare, clinical or non-clinical. Make sure you're bringing others behind you. Looking at policy, right? Ask questions, making sure that policies aren't being passed, voted in, or implemented without your input. Making sure that we're getting educated, always be learning. And that's something that we talk about a lot. And to that same note, I would love to encourage all of our Northwell team members who are on here today to visit Northwell's new Inclusion Academy. We launched it last October, and there are tons of resources to links, videos, articles, trainings, other opportunities to learn and experience here at Northwell that will be made available in the upcoming weeks. So make sure that you're taking steps and being intentional about the actions that you're taking to learn about all of the amazing things that our panelists just shared. To our tech team, thank you all behind the scenes for managing everything. We have to acknowledge you because these events can only be successful with your support. And as mentioned earlier by Dr. Andrews, please be sure to look out for our next Let's Talk About Racism panel discussion on June 17th, which will also be from 5 to 6:30 p.m. And that particular event will be hosted by our Jewish Bridgesburg. The recording will be made available and sent out to everyone via email. For those of you on Northwell Live, you can certainly keep an eye out there as well. But again, panelists, thank you all so much. You all are absolutely amazing. We know the many challenges that you're facing as clinical experts in your fields, but just know that we are all here. And Dr. Andrews, this goes for you as well. We're all here supporting you all, rooting for you all, and excited to lead by your example. So thanks again, and everyone have a great night. Please continue to stay safe.
Thank you, everyone.
Thanks.